Okay, so this is just the second part for the lecture, essentially. So when we look at chronic pain or even like neuropathic pain, we have to really look at the entire disease process and how we treat it, essentially, too. So big things that you have to consider, is there underlying depression or anxiety that are contributing to it? But once again, it's hard. It's kind of a gray area because once again, you can be in chronic pain and that can exacerbate depression. However, they go hand in hand. So really, if there's depression there, treating that depression and even using an agent like I mentioned before that has like a norepinephrine component and serotonin can actually help their pain. You got to treat things like sleep disturbances. That will definitely increase the patient's pain if they're not sleeping well. Once again, it's hard because if they're in pain, they have sleep issues as well. Work-related issues. The biggest thing is making sure that we're getting these patients functioning as well as they can. So working with them on different areas like that. Treatment expectations is a big thing you have to really discuss with these patients. Unfortunately, when they're in that chronic pain, there's times where it's very difficult to get them at a state where they are not in complete pain relief, unfortunately. And I think a lot of patients understand this. They get that. And really, it's more about maintaining their quality of life. And at this point, a lot of times, referring your patient to, like a pain management physician, because a lot of times they can do different procedures with them, or there's a lot of different pain treatments that primary care, it's not within their realm, essentially. So a lot of times too, like, having them go see other, specialty areas can be helpful. Or even areas, things like hypnosis or acupuncture. There's a lot of, alternative treatments out there too. And some it works for. So social support's a big thing too. Obviously, like I said, that quality of life can be impacted by a lot of this. In terms of aging and pain, there's a lot of conflicting research studies on it. They found too that there can be an increase in that pain threshold. There's a lot of chronic disease, and obviously in aging or in the aging adult. And they have changes like they may have diabetes or vascular disease. They may have peripheral neuropathy. So there's a lot of disease states that can interact with this. The thickness of their skin, just basic things, like those nerve endings may be more sensitive in that patient. They may have a decrease in pain tolerance. And once again, too, you have to really watch the medicines that we give them. They may have an alteration in drugs and metabolites. Because, too, you got to think of side effects of certain meds, or I'm trying to think of a good example. But obviously, there's some that can cause damage to peripheral nerves. So we have to be careful with what we put the patient on because it can exacerbate things. Or you go the opposite route, too, and the meds that we use to treat them, you have to be very careful because it can cause other issues like falls and, balance issues and things like that. In terms of temperature regulation, we'll go through this pretty briefly. I just want you to have a good foundation of understanding how it's regulated because it becomes important when we talk about things like fever and how it's essentially regulated through our nervous system. So once again, obviously regulations of our temperature can be variable, and it's things that can affect it. Obviously, can be your activity. These are basic things. The environment, your circadian rhythm, your gender, like even in women, like your cycle changes your temperature, and you have spikes with with ovulation. You'll see changes with your temperature. So obviously, your circadian rhythm can affect it. Gender can affect it. You have peripheral thermal receptors in your skin, and then when we have your central obviously in your hypothalamus, but obviously it's integrated between your spinal cord and even your abdominal organs as well. But most of it is under that control of your hypothalamus. So that's kind of what controls the set point of your temperature, essentially. In terms of heat production and conservation, these are things that you probably have, gone through before. But obviously, you think about like skeletal muscle contraction. That's going to increase muscle tone and shivering. That's going to affect your body temperature. Your metabolism. So even like your metabolism during like a fever, for instance, it's going to go up. And that's actually what's producing heat too. Chemical thermogenesis, obviously like epi or norepi, that can increase your basal metabolic rate. Vasoconstriction at the peripheral level can obviously affect your temperature too as well. And voluntary mechanisms, those are things like thirst or the amount of clothing the patient obviously wears or the environment. I added this. I don't expect you to memorize all this. I just wanted to add in different things of like how your body temperature decreases, how it increases, and how your thermostat, essentially, which is in your hypothalamus, kind of activates these mechanisms, whether it's warming or cooling. Um, and obviously, too, it gives you examples of like your voluntary responses. These are things like clothing, seeking heat, general things. Um, and obviously, the receptors in your skin. But once again, like you have vasodilatation, to increase heat loss, sweating to increase heat loss. So that's why like you get diaphoretic, obviously, and that's all to reduce your temperature. These are pretty basic, and I don't expect you to memorize this. It's just to kind of give you, the differences here. Like when you have, to activate your warming mechanisms, that's why you shiver to generate heat. Your sympathetic nervous system obviously can change your vascular system. So obviously you can get vasoconstriction. So that way you get heat loss, or I'm sorry, reduces heat loss. Piloerection is actually when you get your hair stands up essentially like on your skin, and that's what it is. And your metabolic rate. Or this is essentially an easier way to look at it. But like I said, the big thing is just understand that it's your hypothalamus and a lot of these other factors between your vasculature um, and, like your metabolic rate essentially, controlling this. These, again, I don't expect you to memorize these. You probably have done these before. These are essentially mechanisms of heat loss. Like you can have radiation or conduction or convection. So they lose heat with conduction through direct contact. Like a good example would be if you have a newborn baby. Like they have a hard time with babies. They have a hard time maintaining their temperature, and a lot of it's because their nervous system is very immature. And it's things too. Obviously, their body surface area and all that. But for instance, you took a baby and you're giving them a bath. You take their clothes off, you put them on a scale. The scale could be cold. That could make their body temperature drop. So a lot of this applies to like when you think about babies and stuff like that. Vasodilatation obviously can change because that's basically increasing blood flow or decreasing. Vasodilatation, increasing it, or if you have constriction, it'd be decreasing. Sometimes too, like, you have that decreased muscle tone and that's like that washed out feeling. And the best way to kind of describe this is of like if you had like the flu with a fever, like your patients may say that their muscles feel kind of weak or washed out feeling. And it's essentially related to this. And a lot of times you'll see it with a fever too. Evaporation, respiration, obviously, and then voluntary measures. With aging, there's a lot of changes. So they have, a decrease in their blood circulation. Even that vascular response of constriction or dilatation can obviously be slowed. Their metabolic rate may be slower too. So obviously the regulation of their temperature becomes impaired a little. They have decreased sweating. That's definitely common in the older adult. Their perception, just because of even, their sense of touch and all that, or perception of heat and cold may not be as great as it is when they were younger. So these are common things with aging. In terms of fever, and we'll talk about this later too as we go through each different disease states, but fever really results from a response of infection or inflammation. So once we get into the immune system, these processes, like, the inflammatory process is what stimulates fever. So underlying inflammation and these chemical mediators bring that on. It's a normal adaptive response, and a lot of times it's from cytokines or prostaglandins, and we'll talk about that with the immune system. But all these inflammatory mediators that respond to infection or inflammation are what really trigger it. And it resets that hypothalamic thermostat. So that's what's controlling your temperature and, causing it to rise. And they kind of set like a new set point with the hypothalamus, essentially. You can have other factors that trigger it as well. Exogenous means outside. Pyrogens, basically from bacteria. So certain bacteria can release toxins or pyrogens, essentially, that trigger a fever in a patient. You may have endogenous pyrogens, so those are internal, products essentially, and these are related to like those inflammatory mediators, like cytokines or prostaglandins, and that will stimulate a fever. Endogenous cryogens, or we also talk about antipyretics. They help modulate that rise in temp and prevent an extreme temp elevation essentially. And we give antipyretics. So if you think about Motrin or Tylenol, those are considered antipyretics. Those are anti-fever agents. And you even have these naturally in your body that kind of halt that process at a certain point so you don't, your temperature doesn't go through the roof essentially. But we also give these to patients with medicine as well to bring that fever down. This is just an example. So you have, those endogenous, exogenous pyrogens that may be infections or toxins, and they trigger this basically inflammatory response and release of agents like prostaglandins or cytokines. And this is what's basically hitting that hypothalamus. So then you get a change in your hypothalamic set point, and their temperature essentially changes essentially. And these are what kind of your hypothalamus and your brain essentially is what kind of turns on these factors. Like if their temp is low, then obviously you're going to do those mechanisms to conserve heat. If your temperature is high, that's when we do mechanisms to reduce the body temperature essentially. And these essentially are just, like I mentioned, antipyretics and NSAIDs. So things like Tylenol or NSAIDs like Advil, Motrin, Aleve, those will work on prostaglandins, and those will decrease the patient's temperature. So it's just kind of a good way to look at it. Another example of what I just kind of went through, it's just a different table. Once again, number one, if you look at this prostaglandin E, pyrogens, those are endogenous pyrogens, so those are things that are naturally produced. You reset that thermostat. Then you have the response. So it's either temperature rising or temperature lowering. This example is with rising, so they have a fever essentially with it. And then here's an example of it lowering essentially. So that's exactly how like fever is, the pathophysiology behind fever essentially with it. There are benefits to fever. It definitely has an effect on organisms and can affect the growth and replication. It decreases serum levels of iron, zinc, and copper, which are ultimately usually utilized by bacteria, essentially tended to help feed them and help bacterial growth. It deprives bacteria of food, promotes breakdown and autodestruction of cells, increases lymphocytic transformation and phagocyte motility. So all those components of your immune system, it essentially kind of boosts it essentially. Production of antiviral interferon. I don't expect you to memorize all of these, but just know that in general, there is a benefit to fever. So it's a red flag, obviously. If you see a patient with a fever, it indicates that there's a systemic process going on. However, like in little ones, sometimes they're more prone to developing fevers, and there are benefits to it in terms of, destruction of organisms. Because it is beneficial, treatment with antipyrogenics, like medications, like I mentioned, like NSAIDs or Tylenol, obviously you have to review them carefully. That's what makes patients feel really crummy, though. So you kind of got to, draw a fine line there. And I would say, like in general, like in pediatrics, they treat the fever. We treat it. And usually it's with like Tylenol and Motrin like that. A big thing to consider, though, is older adults really don't have a great fever response. And a lot of it's, there's just changes with their nervous system and their hypothalamus as well. So they may have a major infection going on, but not present with a fever. This is very common. And actually, this is probably what explains a lot of the mortality and morbidity in older adults, because there's no fever to, prompt a red flag or recognize that there's a severe infection going on in the patient. And it's not that none of them get fevers. I mean, there are patients that do, but it's, not as prompt as it would be in a younger adult. In terms of these hyperthermia, hypothermia, these are things you can go ahead and take a look at. Essentially, this is when you can go into severe temperatures, obviously, and you can have damage to your nerves, or you can have brain damage from it, and obviously death. And there's different things like heat exhaustion, heat cramps, heat stroke. Those are general things that you can kind of take a look at. Once again, go ahead and take a look at this. This is more common in those patients that are out working, in high temperatures. And a lot of times, too, it's patients that are not accustomed to doing this. So maybe someone that was out doing yard work for a very, very long time. They have like a ton of sweating or sodium loss with it. So obviously we worry about electrolyte disturbances. They can have blood pressure changes, rapid pulse, obviously because of the fluid status in the patient. But the big thing, this is more commonly obviously seen in like an ER, potentially urgent care, but if they're that bad, they usually are at the ER. But obviously fluid replacement is a big portion of treatment. Heat exhaustion, you can go ahead and take a look at this. This is just basically progressively further down the line. So obviously this is like from a prolonged high core temperature, or even environmental temperatures that have basically caused, these manifestations in the patient. You can go ahead and take a look at this. Same thing with heat stroke. Go ahead and take a look at this. You can go ahead and read through this. Malignant hyperthermia is another thing that you'll see in the hospital. You won't see this in the outpatient setting, or you shouldn't. It can be, from an inherited muscular disorder, but another very common cause is actually from anesthetic agents or neuromuscular blocking agents. And you may have seen this in the hospital. But once again, this can be a cause of hyperthermia, obviously, and it's related to sustained muscle contractions in the patient. But it's more common in with anesthesia, essentially. Hypothermia is obviously low body temperature, anything less than 95 or 35 degrees Celsius. Obviously, you worry about circulation with this, coagulation, ischemic tissue damage, or even when you think about, like getting frostbite, you worry about the cells, obviously, at that area too. So you can go ahead and take a look at this. I think you understand accidental or therapeutic. There are times, obviously, now I'm sure you probably have already heard about this, about, preserving ischemic tissue, and they do stuff like this even in surgeries, like with the heart, and there's a lot of different new treatments out with, therapeutic hypothermia, essentially. Go ahead and take a look at this. This is more that you would see like in ER. So let's talk about sleep-wake disorders. This is very common. You will come across this absolutely in the outpatient setting for sure, and I'm sure you've had it in the inpatient setting as well. Some of the common ones that you'll see obviously are insomnia. Some other ones that you'll see is like restless leg syndrome, obstructive sleep apnea is a huge one, and that's one that we really need to start recognizing better. Narcolepsy can occur, or you also see circadian rhythm disorders. That's actually common in healthcare providers because of our shift that we work, essentially. In little ones, sometimes you'll see like those nightmares or night terrors in kids, and we'll kind of cover through these as we move through. So sleep is actually like a multi-phase process. It obviously has like your sections of REM and non-REM sleep. But the big thing to understand is that it provides restorative functioning, essentially, and it promotes memory. So sleep deprivation can have a lot of negative outcomes, essentially, on patients' health. So really, it's a time that, our body should be healing. Your hypothalamus, once again, is like your major sleep center. And there's different, chemical mediators like hypocreatins and histamine that can affect your level of awareness or sleep, essentially. Like if you think about histamine, and we'll talk about this as we move, further into the course, but think of an antihistamine. Antihistamines actually make you tired, like a Benadryl. Well, it's, an anti, so it's working, it's basically turning off the histamine response, where histamine normally in your body is actually promotes wakefulness or that rapid eye movement during sleep. But it's just an example to kind of put it in perspective when you look at like an antihistamine. But histamine, obviously can, affect the patient's wakefulness. There's two phases like REM sleep or non-REM sleep. And then when we look at non-REM sleep, it's the good portion of your amount of sleep. So 75 to 80% of it is non-REM. And you can do like sleep studies on patients, and they'll do EEGs. There's different stages, like stage 1, 2, 3, and 4. I don't expect you to memorize these, just big concepts. Look at stage 4. If you look at stage 4, that deep sleep, growth hormones release, level of steroids and catecholamines are depressed. So if you're not getting good deep sleep, you're going to have elevated levels of steroids, or you're not reducing them. You're not depressing those catecholamines like epinephrine or norepinephrine. So obviously that can have an impact on the body. Just think back to stress, about how we talked about corticosteroids and catecholamines. So if you're losing this, it can have a negative impact on your body, not just your brain as well. REM is 20 to 25% of your sleep. This is the time where your brain's really active, and this is usually when you have vivid dreaming. It's also known as paradoxic sleep. Usually it's because you'll see these EEG changes that are similar to a very awake pattern or a normal wake pattern. You'll see a lot of activity with this. It typically occurs like every 90 minutes, usually beginning like an hour or two after you fall asleep. But everybody usually will have these spikes where they have REM sleep essentially. And they have rapid eye movement, but your temperature tends to be suppressed, and your heart rate and your blood pressure will change with this as well, and also your cerebral blood flow. This is an important area I wanted to point out. In terms of aging, like their total amount of time of sleep is decreased. So not only do they take longer to fall asleep, but they also tend to awaken more frequently. And there could be multiple factors that cause this, whether it's their medications, like they're on diuretics, or even just underlying disease states. They're in pain, or they have to get up to urinate at night. So they have a lot of interruptions in their sleep as well, on top of more of those of like an insomnia or like a difficulty falling asleep with it. Their amount in stage 4 decreases. And like I mentioned, there's a lot of different physical ailments that can contribute to this. A lack of daily routine, rising early, naps, exercise, etc. Changes in their circadian rhythms. Medications can cause different changes with this as well. Other sleep disorders are commonly one that you'll hear is dysomnias, or that's like the overlying term for it. This is probably one of the most common is insomnia. This can either be difficulty initiating or maintaining sleep or excessive daytime sleepiness when we look at dysomnias. However, with insomnia, you always want to characterize, the deficiency there, whether it's an inability to fall asleep or stay asleep. And sometimes patients, unfortunately, have both, where they can't fall asleep and they still have the, wake up at night all the time. It can be primary or secondary. Primary meaning that you can't find an underlying cause to it. They just purely have insomnia. However, you always want to look at those secondary causes because once again, you want to treat that other cause before treating insomnia. You want to figure out if there's something that's triggering them to not being able to sleep. And it's common. Like I'll go through a patient's history or their meds and I'm like, oh, that's absolutely why you don't sleep, or you're taking this med at the wrong time, or etc. Pain's a big one, obviously. Depression, drugs. With depression, sometimes patients either sleep more or sleep less. Drugs are a big one. Always review your patient's drugs. Are there drugs that have a side effect of having sleep difficulty with it? Like, for instance, there's certain antidepressants that some cause fatigue and some actually will cause more difficulty sleeping. So obviously those ones, the ones that have like a lot of the norepinephrine in it, those can cause insomnia. It's usually not that problematic, but I would always tell the patient to take it in the morning and not at night. Meds like Adderall or, for ADHD, obviously that can keep them up at night. So always assess whether they've had changes in their medications or a new agent that they've added on, over-the-counter decongestants. I mean, you'd be surprised because patients, unfortunately, sometimes don't know that that's what's triggering it. Caffeine intake, things like that. Thyroid's a big one. If your patient hasn't had blood work in a long time, it's really important. Look at their thyroid hormone. Check their TSH, and we'll talk about that later. But obviously, you can have hyperthyroidism, and that can absolutely affect their sleeping. Or once again, it could be idiopathic, unfortunately. Obstructive sleep apnea is very common, and it's more diagnosed now. I would say it's getting better. But before, I felt like people were just kind of not bringing it up, and clinicians weren't assessing for it great. And it's really, really important because obstructive sleep apnea has a huge impact on a patient's health, like their blood pressure, cardiovascular disease, even like their daytime physical functioning. I mean, they complain of daytime sleepiness a lot. Sometimes the patients aren't that well aware of it. It's more of the spouse or significant other that may prompt them to say, hey, I think you have apnea. A lot of times there are snores, like, so they, are heavy snores that tend to obviously quit breathing with these episodes of apnea, then they gasp for air. So most of the time, sometimes it wakes them up, so sometimes they do know that it's there, but you have others that don't, and you have to have, a spouse or something recognize it. But once again, they get hypercapnia, so that's elevated CO2 levels, and hypoxia. So obviously it's not good. So if you're suspicious of something like this, you obviously send them to a sleep specialist. It's usually a pulmonologist and sleep specialist that you'll send them to, and they can get a sleep study. But a lot of times it's that negative thoracic pressure or the mechanoreceptors, like your CO2 drive and all that. That's what kind of commonly stimulates that arousal, essentially. So it's kind of a mechanism in place to protect them, but it definitely needs to be assessed. Restless leg syndrome is another one that's very common. They tend to have this underlying feeling in their legs that it's like an unpleasant sensation that they need to move them. So obviously can cause insomnia in that patient too. Tends to run in families. It can be associated with circadian fluctuations of dopamine because if you think about it, think about Parkinson's disease. Parkinson's, they a lot of times they have those abnormal rigid movements, like when they try to walk or they have difficulty walking. And that's all related to dopamine. So a lot of times, obviously, it can be related to this too. So it's associated with dopamine. So it can cause insomnia too. Narcolepsy, this is where they have times during the day where they actually fall asleep. Um, you can see it with cataplexy too. Sometimes they go hand in hand. Cataplexy essentially is like where they almost end up with like a drop attack. Like they literally just pass out and fall. Can have hallucinations. It's common to like assess for sleep paralysis in these patients too. Like I would inquire about it, where they wake up, their mind's awake, but they can't physically move their body, and that's common in narcolepsy patients. Um, can be affected by the hypothalamus, and you don't have to memorize all that. Just essentially know what what it is. Circadian sleep disorders, once again, you probably have all, unfortunately, us nurses have encountered this with working nights. And it becomes difficult because you have to treat daytime sleepiness, but then you treat that, and then it sometimes exacerbates their insomnia as well. Like nowadays, like there's medications like Provigil that will give patients to help with daytime sleepiness, but then like you got to watch and make sure that they can sleep at night too. Parasomnias essentially are things considered, or I guess I should say, first of all, they're very much more common in kids. Things like night terrors. It's usually common in that like 6 to 10 or 12 age, like usually like a 6 to 10 age. But they wake up, they don't remember it, but it's very, very frightening to the parents because the kid will wake up, they're like hysterical. You can't get them calmed down. You don't really know what's even causing it, and then all of a sudden they'll go back to bed. And if you ask them about it, they probably won't remember it. And they outgrow a lot of this. But they're considered parasomnias. Like sleepwalking is one of them. Talking in your sleep is another one of them. So any of these, things, a lot of times they don't remember it the next day. But exploding head, your textbook brings it up. But that's essentially like when you're going to sleep, and I'm sure everybody's experienced this, but you like wake up suddenly and it kind of jerks you. Like you wake up very acutely. I don't. You probably have to experience it to know what I mean. But that's essentially a parasomnia. This is essentially just talking about narcolepsy, because unfortunately, if you look at the bottom, misdiagnosis is common. It's highly underrecognized, and I think it's just because a lot of times we don't inquire about it, and I think patients don't bring it up. Like they don't really realize it's abnormal that they're falling asleep all over. They don't even really know. I mean, they know, but sometimes it takes once again a family member to prompt a visit for this. So really, if you look at the onset of symptoms to diagnosis, it's 7 years. That's a long time. And even sometimes they're misdiagnosed at the beginning. So really, just be aware of it. That's the big thing I wanted to mention. But they tend to present with daytime sleepiness, so they're really tired, but they also have times where they have like sleep attacks and they're falling asleep in areas where they shouldn't be, at atypical times, essentially. So I just added this so you can take a look at it. So that's it for this section. And if you have any further questions, obviously, please let me know. Thank you.